Good afternoon and welcome to Statewide Grand Rounds, sponsored by the New York State Office of Mental Health's Bureau of Psychiatric Services and Research Institute Support. I'm Dr. Lloyd Sederer, Medical Director of the New York State Office of Mental Health, and I'll be your host today for this presentation, which we call The Role of the Psychiatrist in Leading Public Health Systems, a conversation with the new OMH Commissioner, Dr. Ann Marie Sullivan. Commissioner, delighted to have you here and look forward to speaking. The New York State Office of Mental Health is accredited by the Medical Society of the State of New York to provide continuing medical education credit to physicians. We select our Grand Rounds topics and develop the content of each program with OMH psychiatrists and physicians in mind. We also welcome viewers from other mental health service systems and professions and hope that these programs will be of benefit to you as well. I want to remind you that the slides for today's program and additional resources are available at the OMH internal continuing medical education website, also sponsored by our Bureau of Psychiatric Services. Please note you must be an OMH employee to access this secure site. But you can also use this site to view archived videos of previous statewide Grand Rounds. We have now a robust collection of Grand Rounds and some terrific speakers that you may enjoy. The website address is listed at the bottom of your screen. If you're not an OMH employee, you can still view archived statewide Grand Rounds videos on the OMH Internet. These videos are posted to our external website about 4 weeks after the live broadcast. The web address for this is also listed at the bottom of your screen. We're going to open our phone lines towards the end of the program, and I'll mention that when we get close. And we invite your questions via our toll-free number, 1-877-280-7400. Please give us a call. We like it when you call. We also welcome your questions and comments by email anytime during the program, and the email address also posted is swgr@omh.ny.gov. We also now have a growing group of people who join us by WebEx, which is our new alternative to GoToMeeting, WebEx. And WebEx participants can only use this email address. If you want to be in touch with us, do it through the SWGR because the WebEx meeting mailbox is not monitored. So we're pleased to, let's get to the topic. We're pleased to welcome to the program today the new Acting Commissioner of the New York State Office of Mental Health, Dr. Ann Marie Sullivan. It's standard procedure for commissioners to be appointed acting by the governor's office until they're officially confirmed, and we anticipate that in the near future. At the center of Dr. Sullivan's distinguished career has been a deep commitment working in the public sector now for over 30 years. Her roles have included that of Senior Vice President for the Queens Health Network. This is a group of city municipal hospitals where she was the CEO not just of mental health but of the entire provision of medical services in this network. She had been previously the Director of Psychiatry at Elmhurst Hospital in Queens, and also roles as Medical Director of Ambulatory Care at Gouverneur Hospital, another HHC hospital, and back some time ago did her time at Bellevue Hospital Center as an attending psychiatrist. So she has a long and important career. She understands our patients, she understands their families, and understands what it means to work in the public sector. She's been an active member of many important committees, including at New York State, the Medicaid redesign team, and she's also been a very prominent leader in the American Psychiatric Association. In the interest of full disclosure, we want you to be aware that all of the faculty and planners associated with this CME activity have indicated they have no financial arrangements or affiliations with any commercial entities whose products, research, or services may be discussed in these materials. That includes Commissioner Sullivan and me. Any discussion of investigation or unlabeled uses of a product will be identified. At the conclusion of this program, participants should be able to first understand some of the main challenges facing the field of psychiatry in general and within OMH specifically, given the phenomenal number of changes underway that we see today in both the health and mental health service systems. Second, identify at least 3 areas where psychiatrists can already and need to be able to provide leadership in a broader care system. And third, identify at least 3 areas where psychiatrists can develop additional skills, where we as doctors can further contribute by learning more, given the needs of our patients and the very changing dynamics of the care sites that we are involved in. So now, with that, let me turn to Commissioner Sullivan. It's terrific to have you here. Terrific to have you at OMH.
Thank you, Lloyd. And I just want to say that it really is my pleasure and actually honor to be able to talk with all of you today. I want to begin by thanking you all for all the work that you do each and every day for our patients. I know that it's challenging work. I think it can sometimes be exciting and rewarding, but it's also difficult. It can be hard. And I also know that your dedication to the public system often means that you're not being paid as much as physicians in other sectors of healthcare. And I just have to begin by thanking you and also praising you for what I think is a really outstanding system of care that the state system has had now for a number of years. And as I talk about changes and things that we want to do going into the future, I'm really just talking about hopefully bringing us up to another level. Not saying that please not implying in any way that what we have been doing so far is not really quality care for our patients. So thank you. And I'd now like to just get into a little bit of probably about 15 minutes to talk about what I see are some of the big changes that we're all going to be facing, the challenges, and the key role that the physicians in our systems, in this system, have to play. And that's each and every one of you. So let me begin with the slide set a little bit, and let me go to the first slide. There are about, these are the issues that I'm going to be talking about as I thread through the rest of the slides. So just to mention them so you kind of know where I'm coming from. The first, obviously, is the one which is closest to home base, which is the regional centers of excellence. And I think that we are really looking to 2 key things here. One is a transformation of the design of the care that we provide. And the transformation is one which is really a part of what's happening nationwide in clinical care, which is moving from the more hospital-based system of care, only being in the hospital when you absolutely need to be, and strengthening and broadening preventive care and community-based care. This is not just psychiatry. This is all of medicine. The second big factor, which we have to keep in mind, which is very real, is the financial pressures that are facing the entire healthcare system. And when you think of what's been happening with the Affordable Care Act, that key word is affordable. And the affordable is 2 pieces. One is getting more people insured, but the other is designing a system of care that is ultimately also more affordable. So basically, the whole system is shifting in these 2 arenas. The big emphasis on inpatient care, quite frankly, is because that's where the bulk of our dollars are being spent now. But we also realize that perhaps if we do some things differently, we could spend less there and move those dollars into community-based care. So that's one big thing. That's the redesign of the Centers of Excellence, and I think I'll get into it more in terms of what excellence might be as we go on. The second big push that's coming through the Affordable Care Act and in basically throughout medicine now is the real integration of medical and psychiatric care. I think this is really exciting. For many years we were kind of split off, to tell you the truth, where I think behavioral health sat on one silo and medical care was in the other, and we're trying to repair some of that now and make sure that there's true integration. And there's many ways to do that. Some of it is collaborative care in primary care, where you actually have psychiatric physicians consulting with primary care doctors and assessing and helping primary care doctors treat depression in primary care, helping primary care doctors screen for substance use, helping primary care doctors really work with us collaboratively to improve the health of the patients that they see. The other big piece is us. as behavioral health specialists, making sure that the medical side, what our patients need on the medical side, that they really get it, they understand it, and that they're also in a collaborative practice with their primary care doctors. Having worked in clinics for years, we always had trouble getting our patients to go for their annual physicals or go to see their primary care doctors. And to tell you the truth, I'm going back a number of years now, we weren't very good at communicating with those doctors. It wasn't as high on our priority list, to tell you the truth, as it should have been. And this is a whole big area that in some ways we haven't been as aggressive on. I know some areas of our system have done a good job, others I think are moving to that, but we need to really pay attention to the medical side of our patients, and we need to integrate it. Our patients have to see it all together, but they're not going to do it if we don't, so we begin there. The third part of that big integration is what's happening on Medicaid. And basically Medicaid, all of our patients are going to be in managed Medicaid by 2016. And when all those patients are in managed Medicaid, it means that they're going to be Medicaid plans that are going to be integrating the care both on the behavioral health side and on the medical side. That's a big movement in the state. No state has quite done this the way we're planning on doing it. A couple of states have done it in one county, but nothing on the scale of New York State. So it's going to need a lot of work on the community side. It's going to need a lot of assistance from all of you. What does it really mean? And ultimately, while right now it may feel distant to the state system on the adult side because we're not really reimbursed by Medicaid, the future will be that our intermediate care beds will be linked to that funding in Medicaid. That means that we will now be tighter, more closely linked as part of the entire system of care. And we will ultimately be at risk to be paid for those beds based on our performance. Now that's several years down the pike, but it's never too soon to start thinking about what that means. That basically means that we may be in the position where if we aren't doing care in the best practice way in intermediate care, not be getting reimbursed. So there are key issues here that we have to face as a health system. And then the last piece I just mentioned to just show the investment of the way the feds are looking at it. This isn't as directly impinging on us, but there's a huge pot of money. It's called DSRIP, the redesign of inpatient care. New York State, as part of its waiver, which you may have heard of, is going to get $7.2 billion to basically redesign inpatient care. And the redesign of inpatient care means basically that there's less inpatient use, more outpatient use of care, more wraparound services for patients, and basically less readmissions.
And this is for medical services, surgical, psych, everything.
Everything. That's why it's such a big pot of money. Now, behavioral health, what we're going to be working with as the state system is with providers out there to make sure some of those dollars come to behavioral health, that basically to prevent readmissions in the Article 28s. But it gives you an idea of the commitment of the dollars at the federal level to this system redesign, and we're a part of that system redesign. So those are the things to keep in mind as I go through what I think some of you may be more familiar with than others, so forgive me if you know some of this stuff, but just to go through it so that you can get a sense of where we're going. The Affordable Care Act is based on a concept of a triple aim, which actually began with Don Berwick when he was working at IHI. And if you remember, he was the CMS commissioner for the feds acting that never got finally approved. But his footprint is all over the conceptual framework of the Affordable Care Act. And he talks a lot about something called the triple aim, which some of you may know. But I think it's critical because it really is the theoretical basis for how the transformation in care is happening. And it's kind of like it's one of those triangles, remember in geometry, the equal-sided triangle? And the principle here is that you can't get any of this to work unless all three sides work together. And the three sides, the one side of the triangle we're most familiar with is better care for each patient. This is our best practices. This is what we do when the patient who is ill comes to us, whether it's in the state system or in the voluntary system. And basically involves all the best practices we do. It involves all our care transitions. It involves inpatient. It involves outpatient. And that's the care for the patient. The other two sides of the triangle, we have not, as a medical system across the country, been as involved in. The one is the population health, which is really a concept that we're not just dealing with illness, but we're dealing with wellness. Now, for us, that has meant the whole recovery movement and the wellness movement for our seriously mentally ill patients. In the community, it means things like depression screening and taking hold of the fact that large numbers of depressed patients are out there and are not being treated. It involves things like suicide prevention. But it involves thinking of the health of a population. That means that even if you're an inpatient doc and you're only seeing patients when they get to you because of an acute crisis, you have to be thinking about what is their wellness plan going to be when they leave. I mean, how are they going to take care of all the recovery issues and also all their medical issues? And how are you going to help their families deal with this? Because families get involved and they get stressed. And what's the wellness of the community? Very different approach to say that that's as important as what we do on inpatient services, as important as our cardiac surgery, it's as important as our very successful treatments for cancer, that wellness of the population is just as important. Now, the last piece of the triangle is the thorniest one, which is that at all times you have to be thinking of the cost of what you're doing. This has not been something that's traditionally been thought of really at the core of medicine, and less so even in public sector systems. I've worked for many, many years in the Health and Hospitals Corporation, and a lot of physicians, quite frankly, part of the reason they worked at the Health and Hospitals Corporation was because they didn't have to worry about sending out bills. They didn't have to worry about whether or not their practice was thriving or not thriving. They had a salary, and they could do what they felt they wanted to do. And now, before I left HHC, we were really working very hard with them to consider the cost of care and to consider what they're doing when they're prescribing certain medications, to consider when you ask for certain tests, to consider the cost of an admission versus a wraparound service in the community. Why consider the cost of care? Well, because in this country it's been exponential. It's just been kind of off the charts. And now we're beginning to slowly kind of bend the curve, and basically the payers don't want to pay for it anymore. Whether it's your employee plan, I'm sure you won't have family members who are paying very high rates every month for their insurance, or the feds through Medicaid and Medicare. So the cost has to be filtered in. So it's these three things that we're dealing with. And I can honestly say, having been in the public sector, whenever cost came up, it was an issue, and I bristled a little bit. I felt like, I shouldn't be worried about that. I should just be worried about the best care for my patient. But there are limited dollars. And what is the best care for the patient? And if we don't consider cost, we could be spending the dollars maybe not in the best way. My message to you is dollars are precious, that we only have a limited pool, whether it's the state system or the entire country. And how we spend it really kind of is important. So we have to think about that. It has to be on our minds. Now, why am I addressing all this to you as physicians? Because I think, I don't care what your role is in our system, you're a leader. If you're a team leader on a unit, it's a critical leadership position. If you're I don't mean just, but if you're a staff psychiatrist serving our patients in the clinic, you're a leader. By dint of the fact that you're a physician, that you have a level of expertise which is different than anybody else, you have the ability to truly see the big picture, if you choose to, and to be a leader and a role model in how we approach care going into the future. And I have to ask each of you to take that position. Now, in systems of care where physicians are often employed, sometimes you can kind of get caught in this thing where you feel like, well, all they want me to do is sign prescriptions in the clinic. Or all they want me to do on inpatient is, move the patients through. I'm asking you, and I'm committing, I'm going to work with you as a team to see physicians' roles as more than that. To see physicians' roles as working clearly with our patients, number one, but also being one of the forces that can help us redesign the system.
Some people have called this type of leadership expert leadership rather than structural leadership. They don't have an executive position, but they have the expertise that confers leadership upon them. Yeah.
Absolutely. Yeah. And you guys do. You really do. And I think we as a system have to help use that expertise. We have to get out there and help develop that piece of in terms of treating patients, it's great, but there's this leadership piece which we have to work on. And I'll be working with Lloyd and others for advice as to how to do this and how to have the medical infrastructure within our system become more leadership roles. So you can be change agents, or you can not be change agents. In my experience, this isn't unique to physicians, but what I would ask of you is that as we come forward with these changes, that before you think that or maybe your negative first impression, to try to hold off a little bit And if that's your first impression, if it's negative, and give it a shot, give it a chance. If you think it's great, great, I'm glad. But I'm asking otherwise. You know, physicians, having worked, especially on the medical side, when I worked with surgeons, you know, you would come in and you would talk about things like decreasing length of stay and doing wraparound services in the community, and they'd go, I know how to provide care, I don't need you guys coming in and telling me to do it differently. You know, when that was said, every nurse heard it, every social worker heard it, everybody heard it, and everybody would just kind of deflate. They say, okay, you know, Dr. Jones, the chief surgeon, doesn't want to do this, nothing will ever happen. So his role was so key because he had such an influence on everything that happened around him. And it would still and it would happen with the surgeon who came in at night and said, you know, I don't agree with this new stuff that they're doing. So I'm just saying to you that you're role models, you're experts. I'm asking you to try to work with us. I also need your ideas. You know, one of the major things I've learned over the years in looking at systems and designing systems that while some degree of leadership maybe comes from senior people, nothing works if people who do the work aren't involved in understanding what to do. So we're going to be involving you as leaders in that process too. It'll take a little time to get it organized, but we need the people whose feet are on the ground doing the real work to tell us what we need to do. Okay. So the better health of the population is pretty much what I've talked about. It's collaborative care, it's community-based, reducing stigma. This hospitalization readmission stuff is really important in the centers of excellence. There's a lot of concern, and I think concern realistic concern, that when you drop beds, you can destabilize the system. And I just want to say that one of the things we've been successful in doing is getting some startup dollars, which we will be using to do some of the redesign, some of the community-based services before we drop the beds. So, for example, home-based crisis intervention work with children, we'll be setting up those slots before we close some of the beds. On the adult side, we're going to be getting some dollars for mobile teams and respite beds before. I'm trying to set up some of this before we further decrease beds. Over the years, I know there's been a constant dwindling of beds in the state system. What's an opportunity now, we're getting some reinvestment dollars to do it. Reinvestment dollars to the tune of $110,000 per bed that closes. That's significant. And I think if we're wise and we use those dollars well, if we use this upfront money well, if we use, we can really have the support to redesign the system. And we need your input as to how we're going to do that. So it's just a little bit of an opportunity here. Instead of just decreasing beds, we're getting reinvestment dollars. And there's a real commitment to that. You'll see it when the budget comes out. And we have several years to implement all the changes that are in the reinvestment, regional centers of excellence. One of the things I need to clear up on the regional centers of excellence is the whole plan has not been put on hold. There were some changes in the plan in the southern tier, in Binghamton and Elmira, and up at St. Lawrence. And those are the only changes that have been approved so far. So I need you to be aware of that. There have been some, I think in some ways the press release maybe was a little confusing to people, but the reality is that the regional centers of excellence, the body of the plan is still moving forward. I'm not saying that there might not be some minor modifications in some ways, but it's not that everything has been put on hold. So I really need you to kind of be aware of that.
Thank you for clarifying that, because I think it's been confusing to many of our colleagues about what's happened or what's not happened, as if this whole enterprise were just put on pause, and that's not the case at all.
It's not. It's really not the case at all. And I think this is an opportunity for us really to rethink our system of care, and also to do things more effectively and more efficiently, and be able to avoid, quite frankly, what has been the collapse. If you just look at the collapse of some of the hospitals in New York City and upstate that weren't able to adapt appropriately to some of these massive changes that are happening in healthcare, and we're not immune from that. So I think we need to adapt, we need to change, or we can be extremely vulnerable too. And I think this is an opportunity to do it in a way that designs a good system. I was around, old enough to have been around in the deinstitutionalization days of the 60s, 70s, 80s. I worked on mobile crisis teams that dealt with the homeless right after what was actually not a well-planned process of reducing beds. So I know how destructive that can be, even from well-intentioned people who felt that this was the right thing to do. So we have to be careful, and we're going to try to be careful. I'm not saying everything will be perfect, but part of that was the push to be able to get some of these services up as we decrease the beds. So we try to balance that off. But I do think it's the best thing ultimately in the future. So that's the better health for our population. I would just love to show this slide because the disability worldwide, which you probably all know, is just huge for depression. Just huge. It stands there. It's just slightly, I think, it's almost a tie with cardiac, just a little bit, but, you know, huge worldwide. And we haven't tackled this when we think about population health. This is just something I know you all know, but I like the slide because it shows how clearly our patients have more of these medical comorbidities. And this all pushes toward the importance of thinking of our whole patient together. Behavioral health, medical care, the whole patient when they come to see you. This, I think you've probably all seen too. It's, again, just a quick slide that shows that the more risk factors you have, the more trouble you have with cardiac disease, and our patients have all those risk factors. So there's much higher risk for cardiac illness. Now, it doesn't mean sometimes you can stop those risk factors, but then you have to make sure that they get well treated by their primary care doctors, that they see them, that they get the meds that they can use to help modify what's going to happen because of the risk factors that they have. One of the things there, just to go back for a second, is smoking. And, you know, we've done a tremendous job, great, at decreasing, not having smoking any longer in our inpatient facilities, but we're going to have to move to totally smoke-free campuses. And there's going to be some pushback from that, but we're going to have to do it because smoking is one of those things where you're really not taking good care of your patients.
It is the number one preventable cause of disease and death in this country. And among our patients, it's 2 to 3 times as much.
It's really kind of, I think if we step back as docs, it's really unacceptable that we in any way kind of help or promote that. And believe me, I come from the days of smoking rooms in psych hospitals and days when you had smoking breaks. We had a kind of a belief then that, well, you can't do anything about it, that patients are under too much stress. If you try to stop the smoking, nothing will work. And we've been smoke-free now for years on inpatient services when patients are in the worst phase of crisis. So this is really something I think we have to take on and make sure that all our campuses are smoke-free. The better care for each patient. The thing I want to emphasize here a little bit is best practice dissemination. You guys have been great. I mean, I think clozapine has been taken on in a way that is really impressive across the state system. Believe me, out there in the community, people are not using clozapine the way they need to. So you guys are really the leaders in that. But I think we'll be looking at other kinds of best practices to spread across the system. Sometimes docs see this as a little bit of cookbook medicine, but I think we're getting away from that. We're going to be measured in the future on things like, and maybe in some of our reimbursement rates on polypharmacy, other things. These are some of the measurements that are coming out from CMS, which will probably happen. So we have to really begin to disseminate best practices, and you guys have to be the leaders in that. There's nobody else that's going to take that on except physicians. And so as we do this, we need your input, we need your feedback, we need to make sure we do it right, but we really need your help. I mean, it's just so critical. And I think that the world of medicine is so complicated now that we really need to be able to have certain protocols, certain things, because otherwise we're just not successful. And having worked on the medical side, I've seen infection rates on the medical side drop dramatically when protocols were put in place. And for years, docs said it's not going to make any difference. And yet I've seen it drop dramatically. So I know we can do that with the kinds of things that we have in our system, too. So I just ask for your help and your cooperation with that. The last bullet here is really tricky. This is really patient-centered care. And, in 2 seconds, I can't define patient-centered care. And I think we need to put our heads together to what that really, really means. It's not easy. It's not easy. If you know, docs in private practice talk about patients coming in with all the information on the internet and saying, why are you giving me this pill, doc, when I should have this pill? And this one looked good, and I saw this one on this, and my best friend takes this one. He's doing better than me, so why aren't I taking that one? And this one does. And they all, and I think we have to begin to see that there's a new era here of patients being informed, patients knowing things, much, much more than in the old days when I was first practicing. And our patients are going to be there too, just like that. And we have to think about how we work with them so that they are truly engaged in their care. I think that partnership issue between us as physicians and the patient, and you are the most
powerful influence that that you can have with a patient. You're the doctor. Now I know you feel probably sometimes that people don't feel quite that way anymore, but the reality is a patient sees you as a doctor. And I don't care what else anybody else says. And your role with them, and then how you engage them, how you partner with them, how you listen to their needs, and how you modify maybe some of what you may think based on what the patient may want. This is not easy to do. We're going to have to get together and think about what it means across the system. And I'm going to be inviting some of you to be a part of that, to be discussions with us about how we deal with this. I think there's no simple way, but I think it's something that medicine in general has to face. It is not, take my word for it, it is not unique in any way, shape, or form to us. When I was at Health and Hospital, we had I'm almost embarrassed to say this, but we had to have an initiative to make sure that when doctors, and this was residents and interns, went into a room, that they introduced themselves to the patient. That they said, "Hi, I'm Dr. Jones, and I'm the hematologist," or "I'm Dr. Jones, and I'm the psychiatrist." You know, it's you begin to wonder sometimes, but we've gotten a bit away from the concept of what does it really mean to be patient-centered. We have to put these pieces together. So I think it's just very critical that we do this. This is just to look at. This is a little bit around the issue of clinical integration and care and how different models kind of send it up. You can look at that afterwards. One last thing about lowering the cost of healthcare. The big thing here is that when anybody looks at the numbers, it's inpatient care is the most costly. The question is, and certainly in the Northeast, inpatient care is the most costly in the country. We also have some of the best medical centers in the country. We have some of the best practices in the country, but you can't kind of get away from our cost curve being so high. So the question here is, how do we deal with this? We're at the hub of this in terms of being a largely hospital-based system. But our clinics are part of it too, because part of the clinic's job is to kind of not let patients get to a point where they need to be hospitalized, but to work with them. And as we do the transformation of our regional centers of excellence, we're going to have to look very carefully at the kinds of community-based services, and we may be asking some staff if they would be interested in taking part in those community-based services, which are different from the traditional inpatient service or even our clinic services. By that I mean maybe some home outreach services. By that I mean going to out into the community, being part of a respite team, being part of a mobile crisis team. That's a different skill set. It's something that we're going to have to learn in a different way. It's a different kind of teamwork. But we're going to be talking about that because some of our physicians, some of our nurses, some of our social workers may be moving into other kinds of positions to do more community-based services rather than just the hospital-based services. And I think we need to understand what that means, what kind of training, and we also need to talk with all of you about how to do that well, how to do it really well. So that's a key thing that's going to be coming around. We're going to have lots of discussions about this. But when you redesign a system, you also have to redesign the workforce. You have to redesign what people do. And we need a lot of advice and a lot of help in doing that. And similarly with our HARP and recovery, health and recovery plans, this is a major challenge for the health plans. They don't know quite what to do with this in the beginning. What are we talking about employment, peers? How do you pay for that through a health plan? But they will be doing it. It's part of the RFI and the RFQ that went out. So that we have a lot of work to do here to make sure that we really get the very, very best services for our patients. And that includes these kinds of wellness activities, not just, I don't mean just, but not only medications, not only even talking therapy, but really these kinds of wellness and recovery things, and also chronic disease management. The last thing, I just want to go very quickly, because I'm going over time. I think this is one of my favorite slides because it shows what readmissions happen in our system. This is the entire system. This isn't just state system. This is admissions across the state in all hospitals. And there's that little section which says that patients without mental health and substance abuse who are readmitted to the hospital, and that's about 149 million. And then you look at patients with mental health and substance abuse who are readmitted to mental health and substance abuse services. And that costs, these are readmissions, about 270 million. And then you look at half of the pie. And half of the pie are patients with mental health and substance abuse diagnoses who have medical readmissions. And that really speaks to the fact that that all those pieces of the pie aren't talking to each other. That our patients, whether they're substance abuse or psych, who are being readmitted multiple times to medical units, are somehow not getting the kind of coordinated care that they need. And that's where the Health Home Initiative comes from. That's where a lot of the collaborative care comes from in terms of looking at what we need to do. This is just another slide that says basically the same thing. When you look at all inpatient services for mental health and substance use, 32% of the cost is related to admissions to mental health and substance abuse services. Almost 70% of the costs are related to our patients being admitted to medical units. So we have to work together on the collaborative care side of things. This is just really oops, I'm talking too long. This is just a real summary of all those issues: the Medicaid managed care, the HARPs, co-locating primary care and behavioral health, focus on wellness and recovery, and the focus on patient-centered care. So that's my first really quick overview of
Thank you.
some of the
Thank you.
issues.
You covered a lot of ground, and really in a way that I'm sure our colleagues are appreciative of, because this is all about what's on our minds and what we're being asked to do as clinical leaders and as leadership of OMH. So thank you for laying such a good foundation. Now we're going to turn to my asking you further questions and also weaving in some of the questions that we've received from some of our colleagues. But let me just pick up here, because as I listen to you, and we recognize you're the first doctor, the first psychiatrist in the New York State Commissioner of Mental Health role in over 30 years. That's really a change, and I can hear, and I think our colleagues can hear, how that's beginning, how that's influencing your thinking and your vision. But can you say a little bit more about how being a physician, having taken care of patients, having led clinical services, hospitals, is shaping your plans, your way of thinking about OMH and what we can do here?
Yeah, I think. Well, first of all, I feel very lucky to have to be a physician and to have had the opportunity to have had the training and the experiences that I've had. You know, I don't think anyone. I have to be careful here a little bit because I don't want to. I realize I'm talking to docs, so I'm a little safe. But I think physicians have a unique capacity to see the big picture. When a patient comes to you, you know, you're responsible for everything about that patient. You're responsible for whatever the particular cause they're coming, but you're also responsible for, you know, you feel responsible for how they're interacting with their family, for what there's some other family, what else is happening in their lives. We uniquely are, if we think back, we're uniquely trained to see the whole person. We kind of lose it sometimes over time because of the pressures of how busy you get and what you do, but our training uniquely places us in a position to see the whole patient. And also, if we think back to our training, I think uniquely places us in a position to see the whole interaction of the patient in the system of care. I also think the buck stops ultimately with the doc. We sign those discharge plans. We're the ones who say that a patient can leave an ED. That's an awesome responsibility, but it also means that you have to be able to see everything that's going on. So I think doctors can do so much more in terms of leadership, in terms of design. I think sometimes that hasn't been the case. Mm-hmm. In all the positions I've had, quite frankly, I've often used physicians, but asked physicians to be in leadership positions in my clinics, to have physicians be leadership positions throughout the system, because I think they have that unique talent. That is not to say that nurses and social workers and other administrators also have. But I'm talking to docs right now, so I'm encouraging you to think about that, to think about the unique training that you have. Now, coming into this position...
Now, our principal audience is docs, but we have many
yes,
other...
I don't mean to be saying to everybody else.
But I think it's important because, you know, even one of the questions that came in from one of our clinical directors, Dr. Mary Barber, points out that many of our doctors have felt marginalized. It's not that that there isn't important leadership for other disciplines, but that mostly doctors have been cordoned off, signing prescriptions, signing treatment plans, and yet feeling the responsibility that you're talking about. So I think you're speaking to the doctors is very important here, and you're emphasizing that this is leadership that is needed.
The thing that's, however, the one thing I think that we have to remember as doctors, and again, I think this depends a little bit on training, is you are part of a team. You're critically part of a team. So even if you're not the leader of that team, you're a leader by expertise, which is what you said. You're a leader by the way you look at the world. And you are looked to. Take my word for it. You are looked to for that level of expertise. So we need to help some physicians who I think have a little trouble in that team coordination world. And that's not unique, again, to psychiatry. I mean, there are entire programs, Team Steps by the VA, others, that have really worked to pull together teams. And a big piece of that is pulling the docs into the teams. If you ever watch any of the read any of the checklist stuff from Atul Gawande on the big point of all those checklists is teamwork, and it's the surgeon in the OR saying to the lowest or the surgical tech, any questions, any comments, anything you want to say about this patient, and the surgeon asks that, and listens and takes on as important what that surgical tech is going to say, as well as what the other residents say, as well as what the nurses say, as well as. So that kind of teamwork is critical. Leadership, it's very interesting. Leadership is not telling people what to do. Leadership is engaging people with you in what's the best way to do something. And we have to be careful about that, because some docs see leadership as what, if I say it, it should just happen. And that's not it. And that's never been my ability to do. I mean, I can tell you, I've been in leadership positions and it don't work that way. So you really need to engage people and work with people. And sometimes we need to help some physicians do that. But I do think if physicians can do that, they can have a prominent role in the leadership that's going on. So we need to help people do that too. And, you know, you can't just kind of grumble about it. We've got to work with you and help physicians see how to have a different kind of role in the team.
So we can see how you're translating your identity as a physician and your experience as a leader into already. Let me just take one sidestep first and then come back to some of these questions. But I understand that you recently became a grandmother for the first time.
Yes.
And you must have a picture.
Yes, I do, and I gave it to them to put on because I had to do this, guys. So one of the things that isn't he wonderful? He's cheering.
This
us on.
is the wave. Is this the OMH wave?
Yes. But his name is that's Cezanne Stephen, and he's so precious. And I think one of the wonderful things, and I always feel that working with residents, I don't mean to say this in the same way, or working with youth, they keep you having babies, having grandchildren, keeps you young at heart, and helps you begin to see the future. And it's a really positive thing. So anyway, I had to show you.
Right. Well, thank you. That was lovely. Swinging back around, in order for us to get the job done, we can have all of this goodwill and we can have hope, but we need assets. We need resources to achieve on the mission. And you began to say how some of the inpatient resources can be repurposed for outpatient care. But can you say a little bit more about protecting the assets that OMH has, about repurposing them, about rebuilding in a way that doesn't leave us shortchanged?
Yeah, I think it's a critical point. I mean, in many ways, how you finance, how you pay for things is just critical. Now, let me just say this: I think that the commitment to reinvestment is significant. I think that $72 million, if you add up, if we were to close about 650 beds, it's about $72 million over a period of somewhere from 3 to 4 years. That's probably 70% of the savings. So there's a certain amount of money that, the state would take to kind of offset some of our other issues. That's a lot of money. There's a tremendous amount of money in healthcare. So I do think the redesign is a critical piece. I think upfronting and getting services done is a critical piece. When you talk about Medicaid, managed care, I think a critical thing for us is to keep those dollars separate and preserved. We don't want to end up shortchanging the behavioral health side of Medicaid, of managed care. And I think in our RFQ, we're trying to do that, make sure that there are controls to make sure that the dollars don't kind of get blended and lost.
When you say the RFQ, that's the
That's the
process. That's the
process.
contracting process
Yes.
ahead
And-
for managed care companies to assume
And they're
some of the
coming back and
behavioral.
giving us feedback now, and then we're going to send out what will be a revised product. But a critical thing here is to make sure that we're not shortchanged. And I think that the governor's office and the division of the budget are trying very, very hard to work with us on that. Now, again, you never get everything you want, and you never have enough money. I've been in this business for a long time. But I do think there is a real effort to make sure that if we, in good faith, redesign this system, that they, in good faith, will help us reinvest in this system.
And in fact, isn't it somewhat set up that way, that there's some advance money?
Yes.
And if we do right, then there's more. If we do right,
There's
there's...
$25 million that's it's in advance to help put up services that will help us with the first phase of downsizing some of the beds. Those services will include crisis teams, mobile teams, respite beds, some housing dollars, and some dollars with kids for home-based crisis intervention. The services that we'll be upfronting first will be services that will really help lower beds. So you've got to kind of go with the intensive services first. But we'll be doing that. And I think that that's, again, I think really something on the part of the Division of Budget and the Governor's Office to give us that, to say, and to recognize just how delicate you have to be with some of this redesign of systems for our patient population. So there is some money, and I think that it's significant. I think it's significant, and I think it will help us do that. I think if we do this right, it puts us in a position to ultimately preserve the system and to preserve the care, you know, for our patients. So by and large, it's really a arranging of the dollars, but not easy to do, and that involves some risks, and that's why we have the upfront money.
Right. And you were alluding to also the opportunities for some clinicians to move from inpatient roles to outpatient roles, and that includes doctors and nurses and social workers, psychologists. You want to say some more about that?
Yeah, I think, you know, it's a different mindset, and I think there can be a fair amount of anxiety when you ask people to begin to think of a different mode of practice than they're used to. But I would ask people who have some interest in this to begin to start thinking about it. I love doing crisis teams. In my early days, I was on the crisis teams in New York City, working with the homeless, working with families in crisis, that kind of thing, and I just enjoyed it. So we did home visits, we did all this kind of stuff. But the average doc in those days wanted to know, but they never tried it. They never gave it a shot. So I think what we might do is kind of offer people the opportunity to get out and try some things, see if you like it. But I find that there's going to be opportunities here to learn and grow, and I would ask people to kind of consider that. It's not just, oh, they're taking away what I was doing before. It's what could I do now differently? And I think it can be very exciting.
And
actually.
it's going to take some ways by which people learn how to practice differently, how to practice in different settings. So we're going to have to support our
staff.
staff.
Absolutely,
to
and
do
we're
this.
beginning to think about how to do that training, but we're going to have to talk with staff to understand what they need to feel that they can maybe shift some of this. So, I mean, I think we'll be getting together with the docs and say, well, if you're going to shift from this to that, what do you need to know?
Right.
What can we help you with?
Right. One of the questions that I know you've been asked already countless times, and it's one of the questions that has come in, but we have over 700 psychiatrists who work for OMH, over, I think, 120 internists who work for us, and we are increasingly experiencing workforce shortages, particularly for physicians, not only, but particularly for physicians. And one of the questions is, how can we recruit in rural areas? How do we have competitive salaries? I know that you've been asked this many times, but because this is a broader forum, I think it'd be important for you to talk about that, because people are concerned that we're going to be trying to do something but lacking the personnel to do it.
It's a very, very important issue, and I've started talking to people about it. I wish I had an answer that I could give you that would say we've solved it. But I will say that we're looking very carefully at what the problem is, and I'm well aware of it. I know that we have a large number of vacancies. I also know that there's issues with the salaries being competitive with the VA, competitive with the voluntary sector, competitive with other systems. And we have to try to see what we can do to fix this. Now, this is a state system, so it's going to take a lot of talking about the possible ways of doing that. So I don't have anything quick, but I will commit to making every effort to try and fix this. You can't do the kind of quality we're looking for if we don't have enough of a workforce, if we don't have enough physicians there to do the work. And this is definitely impeding right now our ability to recruit, so we have to work on it.
Yeah.
And,
Some people say in addition to actually having the human capital to do this, we need technology to help us, not as a substitute, but to reach people in underpopulated areas. What's been your experience in the city's municipal hospitals or through some of your other work in terms of thinking about being able to provide medical services through high technology?
Well, I think it's a great opportunity. You know, there's actually some dollars in which we're going to be applying for to see if we can get some to advance telemedicine and especially telepsychiatry. I think it's tremendously useful. You know, I mean, you might think in the city that you wouldn't need it, but what we would use it for occasionally was so that you could have a face-to-face interview with a doc in the Bronx who spoke a particular dialect with a patient who was in Queens, because there wasn't time for that doc to come all the way to Queens, kind of get there, see the patient, and we would have a telecommunication so that doc could do a real assessment in this unique dialect of a particular language. So it can be used in small in settings, but in rural, I think it would be a tremendous improvement. And I think we need to get physicians comfortable with it, and we need to have the technology, and we need to be sure that people know how to use it. In certain states, it's been used quite widely, actually, in rural areas. And I think we need to kind of adapt that. So we're looking to get more dollars to do it and to really set it up so that, especially in the North Country, we can have certain consultations. You can do it with primary care physicians. You can do it with EDs.
Right.
And you can do it with hospital-based treatment as well.
Right. So, in fact, as we were speaking, a question came in from Andrew Kirsch, who's psychiatrist at PI, Psychiatric Institute, and who's asking about EMRs as a way to coordinate patient care. Do you want to say something?
Yeah, well, the electronic medical record, I think, can be a tremendous way to coordinate care. Now, we are invested in the VISTA program, and the state is going to be spreading the VISTA program out through within, I think it's like a 4-year plan, if I'm right. Don't quote me. That goes out. It's going to go to all our inpatient, all our services,
and outpatient,
and it's based on the VA system.
Yes.
The other thing, though, that we have to do, which we're currently in the process of looking into, is how that would be great internally to us, but how it's going to interface with RIOs, how it's going to interface
Not
with,
everybody may know what a RIO is.
A RIO are these regional information organizations, which basically become almost a web-based depository for information, so that if I'm a patient in one part of the city and I end up in an ER in another, I can access care, or if I end up upstate New York, it's something I can access my record from
RIOs
somewhere else.
can also bridge primary care and specialty
Primary
care.
care, specialty, inpatient, ED, ER. So we have to make sure that what we put in place can also ultimately talk to other systems as well, and we're looking at that. But internally, I think it'll be a very solid system that can give us the way to communicate within us. And then we have to be thinking no more of, because this contract was let many years ago, before there was quite as much of this interfacing between multiple systems. So we're going to have to work on that.
Yeah.
But I think it's a critical piece, and it's wonderful when you do it right, especially in care planning.
Well, we're going to give it a shot, and you've lived through an EMR at the city's municipal hospitals, and in fact, HHC I think was one of the first hospital systems in New York to. We
were one of the first, and I think we had, for the time, a really good system, but it over time didn't keep up with what's state of the art now. So the HAC has just invested a lot of money in a new system, and it will be Epic.
Okay.
It's going to be the Epic system, which is big across New York City. A lot of hospitals have it. It's a big investment, but these new medical systems are impressive in what they can do. Electronic systems.
Well, we're going to have a shot at that.
Yes, we are.
So another, did I hear? Is there somebody who's called in? No, not yet. Okay. Because we haven't opened the phone lines, that would be a good reason. So here's another question that's come in that pertains to the Centers of Excellence, which is something you didn't cook up, but it's partly the dish that you've been served. And a lot of us think it's a good idea, but a lot of people have questions, because excellence does mean you've got to do something better, and you've got to have the capacity to do that with people and services. And what are your thoughts here about achieving on this aspiration? What does excellence mean to you, and how are we going to have the people who operate at that level of care?
See, I think I've been talking a lot about the system redesign.
Mm-hmm.
You know, when you get past that, you get to the excellence of care for the particular patients that you're seeing.
Mm-hmm.
And I think, you know, we're responsible for that intermediate care, whatever that means. And I say that not lightly, because I don't think we've really, and I think our system is perfect to define this. What's excellent intermediate care?
Mm-hmm.
What's excellent if someone has not been successfully treated in 2 to 4 weeks in the community, and they need to come for longer care in one of our hospitals? What's the standard of excellence for that? And I don't know that we've ever put that together.
Yeah.
And if we're going to be centers of excellence for that first category of intermediate care, I think we need to look at that. The other thing is, I think we need, and this is where I need a lot of input from the docs, what other populations might we want to have maybe at a center of excellence where in the clinical piece, for example, our patients who have OPWDD and mental illness. Mm-hmm. And there's a subgroup of those patients that are extremely hard to treat both on both sides. Where might we center some excellent care, where we could have an excellent specialized assessment and treatment center that we could learn how better to do that kind of care.
Yes.
So I just think that there's specific patient populations, and then there's the more general patient population. And then the other group of patients I think we honestly have to look at are our very, very long stay patients. Mm-hmm. And I think some will probably always be with us because that's really the best place for them. But I would bet that if we looked at some percentage of those patients creatively, we could think, not quickly, very slowly, work with them to have a different setting than being in a hospital. You know, the Olmstead Act is really very specific about this. This is federal law, that it's critically important that people be in the least restrictive setting. And I think we have to really look at that very carefully. We have to be very sure that for patients who stay with us for decades, especially on the civil side, that we've really done everything possible to make sure that there could be some alternative slowly planned for that patient that could have them back in the community. So what's excellent care in that realm? And I think centers of excellence, I don't think that was, I think the plan spoke to bed allocation. It didn't speak to those issues. So that's something we have to develop together in terms of what are we going to do to really have people look at the kind of care we provide and say, wow, that's a model that Kentucky might be interested in, or some other state might come and say, you know, I want to see what you guys are doing. So that level of excellent care, and that, I think, can be tremendously physician-driven.
Right. And in fact, when you were part of HHC, the part of your work was about improving performance, otherwise known as creating excellence in clinical care, and you worked closely with an organization called the Institute for Healthcare Improvement, IHI. Some of our colleagues may know about that, some may not, but it is arguably the premier healthcare quality improvement organization in this country. And can you tell us some of the lessons you've learned? What have you learned about working with healthcare systems to improve their performance, to improve their quality that is derived from IHI and that you bring here to OMH?
See, one of the things I think that, first of all, I think getting people together in what they consider kind of collaborative engagements. So, for example, all the clinicians from all the set of clinicians from all the hospitals coming together to focus in on a particular issue. One issue could be suicide prevention. How are we going to do this as a system of care? The IHI people, first of all, they get feedback from people who are doing the care, and then they look at models across the country, models of different places, talk with them about what could maybe be implemented in your system of care, and then you learn together how to do it. And you learn from the bottom up as well as the top down.
Right.
And I think that's the critical piece here. A lot of these initiatives have been like just training modules, and then people are supposed to pick it up and magically do it.
Right.
Or the top comes out with something and they just say, okay, everybody go do it. You've got to have this collaboration between what administratively we can do, but the people actually doing the work. How do you implement it? How do you make it happen? And what do they need? IHI is very good at that. They also are extremely patient-centered. So everything that they put in place focuses around the patient, around the family at the same time. So we learned a lot.
This is not a slogan. This is about a whole other way of experiencing the people that we care for and behaving differently as a result.
Oh, absolutely. And I think again, you know, we have a lot of things that our training gave us, I think, which are tremendous. But one of the things I think, well, my years, and maybe it's getting a little better now, gave us was a little bit of a sense that we can just tell people what to do, and
Doctor
if they did
knows
it.
best.
Yeah. And we may know a lot, but if you're going to get patients to really get well, then they have to engage with you, and they may know some things you don't know, and we got to be willing to take that in. But the biggest thing is listening. You know, it's fascinating because even though as psychiatrists we in quotes listen, it's really listening also to what their world is, what their experience is of the treatment that they have. You know, there's tremendous controversy when psychiatrists when the Institute specialists wanted us to have these 360-degree evaluation where patients evaluated us.
Yes.
And I always felt, I mean, how can you not how can you not ask a patient what they think of what the treatment is? I mean, how successful, how's it going? How's it going? Just that kind of question. How often do we really ask?
Yeah.
And listen. They'll say, fine. Don't accept the fine. Say, okay, what's going good, but what's not going so good? You know, what could I do better? What am I not doing that meets your needs? These are questions that, you know, in the old days were asked, maybe a little more sophisticated in the old analytic stuff, but it was always there. We always asked those kinds of questions of patients. We're always curious whether things were working. And I think we have to get back to that a little bit and really engage patients
The
in care
irony
with
is
us.
that in some ways this can make our work easier. It's not necessarily harder to do this. It's actually, in fact, the work not only may be easier, it may be more rewarding.
Absolutely. Absolutely. You know, when I did an initiative on the medical side in the ED, we had a patient who kept coming back and back and back, and nobody knew kind of why. And nobody asked him, well, by the way, where are you? I mean, we knew he was living somewhere because he wasn't, actually, he said he wasn't on the street, but nobody said, well, exactly where are you living? He was living in a van. No, it wasn't on the street. It was his van. But he was a guy with renal disease. I mean, you can't live in a van. You got to keep coming back to the ED, but nobody had spent the time. He was embarrassed to say it.
Yeah.
You had to really coax him. So what are the issues? So we don't often ask patients enough. We don't kind of get the feedback from them enough. And I think that that's what the first step in patient-centered care is that.
Thank you. So in a minute or two, just to let our viewers know, we're going to open the phone lines, though we've been receiving questions. So it may be that you want to give us a call at 1-877-280-7400, or just keep sending in by email. Here's a question from a really good friend and colleague, Greg Miller, who's our medical director of adult services. And he says that the frame that you're talking about not only seems practical and necessary, but what about, the heartaches that, he didn't say that, that's my word, what regulatory compliance does to the lifeblood of hospitals and doctors. He didn't say that either, but he was bringing up the question about, the Joint Commission, CMS, other state regulatory accrediting bodies for us. is that changing, or are we still, counting exit signs rather than asking people about what they want?
Well, let me give one brief example of something at the state we're trying to do, which is the integrated licensure. I think people, I know it's taken a long time, but I think it might actually be at a point now where it's within probably 2 or 3 months, the pilots are up. And it's really an attempt that when a site has multiple licenses for like OASIS and us and GOH, that basically we won't have 3 people coming in and doing all these reviews. We will kind of combine the license, have a regulatory simplification, and hopefully be able to help them collaborate, do collaborative care. So in some ways there's a movement to decrease. But quite honestly, I'm on a measures partnership thing in Washington, developing measures, and the CMS measures get bigger and bigger every year. They get longer and longer. They get more and more complex. I think CMS is not in the mood for decreasing regulation. I think their big concern is, especially during this piece of transformation, that they know what's going on, that they get the data, and that they're sure that things are going right. I think they see some of this regulation as a part of that. So I don't expect there's going to be too much regulatory
So that's an interesting paradox. On one hand, CMS is providing all this money for innovation. On the other hand, they want to know lots of detail about whether it's happening and
it's hard. I mean, in ways you can say, well, why all that? But on the other hand, if they don't know if it's going well, they do need to know. So there's a very real tension about this, and I think it's going to continue for a while. I think what we're going to try to do, as difficult as it is within our system when we can modify things, do that. But I think the world of regulation, the world of measurement, is growing. And I think that's a tide that I don't think you're going to hold back initially.
Well, we need to figure out how to do. We have a call from South Beach. So please, I hope you're still on the line. Tell us who you are and your comment or your question. Have we lost you? Yeah, we need to speak up. We can.
Hello.
Yeah, there you are. Okay. Who are we speaking with?
Hello, my name is Dr. Irene Faraci. I'm a psychiatrist from South Beach Psychiatric Center, Staten Island, New York. This question is in regard to being centers of excellence. Myself and other doctors that I've spoken to feel that we have our hands tied on many occasions when we are not allowed to use the more modern medications for our patients. And
when you're not allowed to use what?
The more modern medications, such as lorazepam as an antipsychotic. And sometimes we have to go back in time and use medications from 50 years ago because we're not given the permission to use medications like lorazepam and the newer medications. So I'd like to know, what are we supposed to do when we have a patient who needs that?
Okay, well, I'll take responsibility for that because I did install a process of review that I personally do around a number of some of the more recent, what I think often are Me Too medications, and within 1 day, as a rule, if your clinical director agrees with your decision, that clinical director is in touch with me, and I frequently approve that for an extended period of time. My objective here was to have people think critically, not to just order the newest medication because it's the newest medication, that there needed to be some thought behind it, and when there is, I think many people would say that I've approved all of those. So you can blame me for that. We want to have independent decision-making on the part of our doctors about what they prescribe, but we want critical thinking. We want doctors to use resources carefully, there's an ample amount of evidence, and many of us have learned from Jeffrey Lieberman and others, that among the different antipsychotics, there's no one that's better than any others, with the exception of clozapine for people who don't get better. So it's about asking you and other doctors to think critically. And when you do, I think you'll find our support uniformly there.
Thank you very much.
Yeah, I think that I agree with what Lloyd said, and I think it can feel to the doctor like, well, why do I have to kind of go through this? But I think that Lloyd's point is really well taken, that we have to be very we have to be conscious of the fact that some of these newer meds Maybe if a patient's been on everything else and you really feel at this point in time, I'd like to try this, that's one thing. What I think we're trying to avoid a bit is if a patient comes in brand new, to not necessarily have to use the newest medication that's out there, which is often the most expensive and shows no efficacy beyond particularly. It's not unique to us. Docs and medicine have the same kind of experience on things that come out. So I think we've set up, I hope we have, if for some reason you're not getting responses quickly, then let Lloyd know. I mean, because that means that sometimes can be a bureaucratic hassle, which I know happens. And if that's happening, then we want to fix that. But I think that the concept that put in place, while I know it's an extra hoop to have to jump through, I think is a good one.
Good. So thank you for your question. Let me turn to a little bit of going back to the system of care, because what you're also asking us to look forward to is something that is different. So when Mike Hogan came to be commissioner here, he brought a message from his national perspective in the President's Commission, and said that the system is fragmented and broken, that the emperor has no clothes, that in fact what we think or pretend to be a system of care is not a system at all. And that was in 2007 when he came here, and that was 2003, I think, when that commission started. Have we made any progress? And if so, where, and where do you think we need to do better?
Well, let me say that, I've been around a long time in this system, and when I pause and think, I think we've made tremendous progress. I know that when I think about what psychiatry looked like, I don't know if I want to give the year that I graduated, but when I finished my residency in 1978, psychiatry is very different. Yeah. It's very different in the public sector from what it was in 1978. And I think there's been really remarkable progress in terms of the kind of care we can provide, the kind of quality we look at, the health and recovery stuff that we're doing with our patients. That's not to say that we still don't have a long way to go, but I think it's much, 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 much better. And the other thing I think that New York, we have to be a little proud of is that despite the fact that we do have fragmentation, we do have silos, we still have much more of a system of care than many states. Yeah. And if you ever have the opportunity to talk to physicians in other states, there are much more, many more issues in those other states, even just in terms of Medicaid coverage, which now is expanding, but which wasn't there in some of the kinds of services we have. But we have a long way to go. I think you always have a long way to go. And I think that one of the biggest pieces, which I think is probably what Mike was referencing, is this coordination in transitions in care. Yeah. When patients move from an inpatient to an outpatient, when they move from crisis intervention to out-clinic care, when they move, when they're better from the clinic care and now they're only going to come once every so many months instead of every week. All those transitions in care, patients are very vulnerable, and our system has not been very good in, we just haven't used best practices, medical or psychiatric, in those transitions in care. And that's what the health homes are about. That's what care coordination is about. And it's probably the biggest deficit we have that makes it all seem very fragmented to the patient. So the patient, doesn't know what's up sometimes because we haven't coordinated.
But it shows us where we need to concentrate our work, yes.
And I think if we do more of that, I think it will seem much less fragmented to the patient, much less fragmented to us, and will provide better care. But I think, it's important sometimes to pause and say, we're not where we need to be, but, a lot has been done. Yeah. And there are certain things that I know probably each of you physicians knows has gotten better in the setting that they're in, and we should be proud of that. Yeah. But we also have to continue to fight that crazy little bit of that fragmentation that we've let go on too long.
And we can take some pride in the work that's been done.
No, I think there's been a lot done.
Yeah. We have a call from Buffalo. Are you still with us?
Yes, I am.
Please tell us who you are and what your comment or question is.
I'm Dr. Diane Analette from the Buffalo Psychiatric Center. And Dr. Sullivan, it was refreshing to hear the passion with which you speak and the encouragement for your physicians to embrace the role of leadership. What my question is I'm wondering, given the push to find our specialty, our centers of excellence, what are we doing for geriatric patients? We do have a graying in New York State, and this is clearly a group of patients that need the specialty of the care that we can provide?
I think we have to be doing a lot more. You know, and actually I have to profess a certain ignorance of what the state system is doing for that right now, and it's something that I need to look into. But I do know that the needs generally of the geriatric population, psychiatric, are critical. And basically, the depression in the geriatric elderly is totally underdiagnosed. Substance use in the geriatric population, but also the process. Now that I'm getting older too, the process of aging and how you continue to have a fulfilling life. What we've found with many of our geriatric patients in the city is the isolation. And you figure in New York City, 8 million people, but the isolation that can happen of someone aging and being alone in an apartment, and what that can do to implement to depression, to other things. So I agree with you, and I think that what we need now, there may be more going on in our system than I know about, so I have to say that, but I do think we need to emphasize it more and more, and I think especially the care for Alzheimer's and dementia patients. While technically I know those patients don't get admitted to our facilities, I think we can, as psychiatrists, can be helpful in talking about the kind of care both in nursing homes and in communities that can keep those patients as vibrant as long as possible. So there's lots we need to be doing for the geriatric population, and maybe I'll ask you. I got your name. And maybe we can talk a little bit about what your thoughts are, truly, about the kind of care we should be putting in place.
Great, thank you.
Well, I'm very fortunate in that I work outpatient in a clinic that is primarily geriatric.
Wow.
We are continuing day treatment because we serve lunch. However, we provide groups throughout the morning and in the afternoon.
That's great.
On any average day,
so we're going to I take the commissioner at her word that you'll be hearing.
Yes,
she'll be
will.
tapping on your shoulder in the future.
Yes, and I think I've seen those kinds of programs, and they're very effective. So we need to talk. We need to talk.
So we got another call and this is from another South Beach colleague. So please tell us who you are and what your thoughts are.
My name is Gene Kaplan. I'm a very veteran social worker here at South Beach. And first of all, welcome to OMH, Dr. Sullivan. My question is, I'm wondering what your view is of the role that the Commissioner's Office can play in terms of working with our contract housing providers in terms of creating a seamless system of care from inpatient to outpatient. We have terrific inpatient and outpatient services, but I think the view of many of us is that the contract housing providers cherry pick the patients who are coming from our inpatient programs. So I'm wondering what might be done about that.
Well, I think it's. I think what you say is very, very important, very valid. I think it's a little bit tricky here because I think we need to be able to get those patients from our inpatient services into housing, and I think we need to get it into the. I think we need to probably have more intensive wraparound services when we move the patients from inpatient to housing. While I think there might be some degree of, in quotes, cherry picking, I think the bigger issue is their anxiety and fear about whether or not they can really contain or be able to successfully work with some of our more at-risk patients in housing. And I think we need to think of a model where we support them in taking those patients. There's some Bridger programs that have been somewhat successful. I think when we get some of this reinvestment dollars, I'd like to be able to be creative with some of those dollars so that there's ways that we can move our somewhat more impaired, sicker patients into housing and have the housing providers feel comfortable that they can take them on. I mean, sometimes I agree with you, it's probably a cherry-picking thing, but sometimes I actually think, having pushed for this for many years from my acute cares, their anxiety about, depending on the kind of housing, if somebody's going to go in like once a week or something to look, I mean, that might not be enough for some of our patients that are coming out of acute care. But we have to fix it. Your point is critical. We have to fix it, and we can't successfully lower our beds until we fix that piece of it. So I absolutely agree with you, and I think, again, although we're going to be getting a group together to talk about this, what could work with housing providers so that we see it as a joint thing in terms of serving these patients.
Even with the Medicaid redesign, I think this is the first time in any state I've known where housing has been regarded as an instrumental part of the treatment plan. And Medicaid is actually that was always a third rail for Medicaid. Never pay for housing from Medicaid. Whereas now we have Medicaid funds being
well, it's a little tricky. The
it's
CMS is, we've been asking,
Okay.
CMS is wavering. And I don't know that we're going to win that one. But,
Oh, okay.
but that doesn't mean that we can't use some dollars to do some of this wraparound stuff in some way.
Right.
And we got to work on that. But unfortunately, we're not getting as much of that as we've wanted.
Okay, well,
from CMS.
we'll get let's work on getting as much as we can. We have too many questions, or not to be able to answer. But one of the areas that has just come up in a couple questions has to do with psychiatric rehabilitation, which is about enabling people to have the lives that they want. And you want to say a few words about that. That comes up in a couple ways, both in terms of the actual services, but also an accent on that, different from an accent on inpatient care or acute, or intensive care, but rather rehabilitation.
One of the things I think that's really exciting, and again, this is Medicaid for me, but just let me talk about the HARP services that we're putting into the specialized Medicaid plan are really quite unique to asking Medicaid to pay for.
Yes.
And they've gone along with this, which I think is great from CMS. So some of it, for example, will be employment coaching and employment. We'll be holding, hopefully, if we're successful, holding our Medicaid plans responsible for making sure that patients get into employment training, employment opportunities, et cetera, so that you can have a kind of get back into mainstream work. Peers are going to be a big part. And then, their first impression was, well, what's a peer? But we talk about having peer counseling, things. These HARP, what they call 1951 services, are really unique. And CMS is going along with us because CMS also feels that rehabilitation, habilitation, recovery is critical. So I think that this is exciting.
Yes.
And this will be through Medicaid. And I think we have to similarly do the same thing
These are
through
financing mechanisms that get us away from the conventional services of clinics and hospitals.
And embed it. See, this is why integration is so exciting. If you can embed it into a medical premium, hopefully you can make it last.
Yeah.
It's not going to be at a pilot
Right.
or
Right.
Something temporarily funded by somebody. It's now mainstreamed into, and that's really very exciting, so that we can continue the kind of, and bigger than just like the pro stuff, really helping people get the fullness of their lives back. And I think that that's a tremendous push. So yes, rehabilitation is critical.
So here's a question that just came in from somebody who's represents our future. This is Dr. Karen Rice, who's a public psychiatry fellow at Columbia, and she's about to, in June, she'll be looking for a job, she says. And I don't think this was a job application, but she is saying, what about the expanded role of the psychiatrist? Is she going to face employment where she's going to be asked to prescribe meds and sign treatment plans? What should she do?
I think, first of all, as a young psychiatrist coming out of a public fellowship, you're more in demand than you may think. I'm just saying that to you personally. So I think you should really, as you go on your job search, check out what's there for the job for you to do. And I think that there are some settings that are beginning to get away from that concept of the doctor signing 1 million treatment plans and just prescribing medications. Because they've begun to see the value of the physician in terms of real treatment planning and real connection with staff, et cetera. I'm not saying it's all over the place, but it's slowly beginning to happen. And I think the more we steer our younger psychiatrists to those settings, the other settings maybe will come along. But I don't think you have to take a role like that. I really don't. And I think that even in, we have big, busy clinics in HHC, for example, but they work with teams. They get involved in innovative practices, just like we do in our clinics. Our clinics do that too. You may not be the clinic director, but you can get involved in teams, you can get involved in new practices, you can be a leader in terms of thinking, what can we do for this population? And actually, systems are more responsive to you in the public sector than you think for that kind of thing. And part of it is speaking up. And part of it is seeing yourself as having, pushing to be a voice if you're not an automatic voice in the way it's developed. And I think that we have some very exciting programs in our clinics in the state system, which have been led by psychiatrists. This whole first episode psychosis team,
Yes.
which is an innovative thing which Mike Hogan had put in place, where people are really doing a whole bridging effect and this is unique.
Yeah.
This is something that's come out of the public sector that I think could be exciting for any young psychiatrist to be involved in. I mean, how do we really work with first episode psychosis and prevent the long-term disability and help the families and work? This is wonderful stuff. So I think that exists in our system. So I would suggest you look. I'm not saying that there aren't some jobs out there that are still just writing your prescriptions and doing this, but I would say try not to go there. I'm hoping that in our clinics we're getting more creative about not having that be the role, and we should talk about that. But there are exciting programs out there, and I think it's an exciting time for public psychiatry because of these innovations and to get young people involved in it. And the other thing I can say is over my career, I found the ability to be creative in public psychiatry greater to some extent for clinicians than in the academic centers where research reigns supreme, but here clinical service reigns supreme. So if you've got ideas, and you get into public psychiatry, I think psychiatrists can have a real impact. So I think it's an exciting field, and I hope you find something that you feel is not, don't take that job.
We're just about out of time, but I think that's a wonderful message to conclude with, which is that indeed the public sector may be the sector where the most innovation is apt to happen in the years ahead. And having been part of academic centers, both of us for many years, we also know just how much like molasses change can be there as well, and with a different set of expectations. Whereas right now, as I listen to you, as I think our colleagues listen to you, they're hearing that the public sector is not only going to change, it has to change, that the forces are inescapable. Let's leverage them.
Exactly.
Yeah.
Exactly. And I think we are in a unique place to leverage that kind of change. And I think that each and every person, hopefully on this call, sees themselves as a piece of leveraging that change, because I do think that the next 4 or 5 years are going to shape what's going to happen for decades in public psychiatry. So it's a time of great opportunity, a time of great risk, but a time, I think, when we can really try to put our patients first in a new and a really creative way that we haven't really had the opportunity for before. So I hope I can get you guys excited about this, and I hope that over the time that I'm lucky enough to be in this position, that we can kind of plan together, work together, to really see what that system can look like.
Well, thank you, and I think it's our privilege to have you as our new commissioner, so welcome, and thank you for being here today. In conclusion, we offer the following take-home messages for clinicians. One of the central challenges facing today's public health is decreasing the disability associated with mental illness, along with reducing the costs associated with all the common co-occurring physical illnesses that people with mental illness have in both directions, in primary care and in specialty care. Psychiatrists and other mental health clinicians also are needed, and we hear that message loud and clear, to bring their expertise, to bring expert authority to impact the future of the public health. Third, integrated care is an important example. It is the model of care that we're trying to achieve, where mental health improves the lives of a great many people while reducing the burden of their illness to them, their families, their communities, and the cost of chronic illness. And finally, as we do move towards regional centers, and we are, we're going to be having benchmarks to demonstrate that indeed we are, and a couple of them will include evidence-based treatments with measurable results, in fact, demonstrating that they were delivered to our patients in all clinical settings. And second, that care was coordinated and continuous across settings in the way the Commissioner was saying. So I want to thank you again for being on today's Commissioner Sullivan, for being on today's program and for being with us at OMH. For our audience, we value your opinion. Please take a moment to complete a brief evaluation for this Grand Rounds. The evaluation contains only 5 multiple-choice questions, and you can also write in some comments. We use this information to shape our programming this year and in future years, and we want that to be useful to your daily clinical practice. So thank you for watching. We hope you'll join us again on February 19th for our next statewide Grand Rounds on pain management. Our guest will be Dr. Charles Argoff, who's a professor of neurology at Albany Medical College and director of the Comprehensive Pain Center at Albany Medical Center, and Dr. Phil Muskin, a colleague many of us know and appreciate for all his great work. He's a professor of psychiatry at Columbia University Medical Center and chief of the CL service at New York Hospital, New York Presbyterian Hospital, and Columbia University. He's also chair of the APA Scientific Program Committee, so it will be his program that we're going to have at the APA meeting here in May. So I hope you'll join us in February, and thank you again for joining us today. Thank you for watching, and be well.